So now they got to go pull the meds, have a pharmacist check it, and bring it back up. So we've had to figure out in what way can we bypass it? What are some systems we can do to minimize that extra work? Because now the tech has a certain number of hours to fill each Pyxis. So that extra trip really trips up their whole schedule for the evening.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On this week's episode of First Case, we are talking about the relationship between the operating room and the pharmacy. And we're going to take a really deep look at the roles and responsibilities of our pharmacists and our pharmacy technicians and really see everything that they're doing. And we're going to be talking to a pharmacist from San Diego, California. Her name is Zahara, and she has been doing this for many, many years, working in the inpatient setting. And she has seen it all, done it all, and even changed it up in the process, because the process, we all know the process needs to be changed from time to time so that we can provide safe care and keep up with regulations and compliance and all of those things. But Zahara has a lot of insight to give us today. She's really going to help us learn everything that the pharmacy is doing. And I think that it will give you some good insight into maybe why there's not a medication in your Pyxis when you want there to be, or maybe why you have to wait a little bit, or maybe even see some of the things that, as OR staff, things that we are doing that might be making it a little bit harder for pharmacy to do their job. So don't go anywhere. We will be right back with Zahara.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Zahara, a pharmacist from San Diego, California. And Zahara, thank you so much for joining us today.
Hi, thank you so much for having me. I'm so excited to be here. It's not often that we get an opportunity to talk about pharmacy and the collaboration that we have within our surgical services. So I'm excited to be here.
I can honestly say that I don't know everything that pharmacy is doing, so I'm excited to have this conversation today.
Neither do I, really.
Hey, at least you're honest, right? But I have an extra special treat, though, for those of you listening today, because not only are we going to be talking to a pharmacist about the role of pharmacy within the hospital and what all that they are doing, we have Stella Yao joining us today, and she has been traveling about, and she's from all over. Actually, while we're recording today, she's joining us from Hawaii. So, but Stella has been a guest on the show a couple of times already, and she is a friend of mine and also a peer, someone that I have met through my involvement with AORN, and we have served together, worked together on different committees and different things. So I'm excited to have her insight and have her join us on the show today. And today we are, like I said, we're talking about pharmacy, trying to understand how pharmacy supports us in the operating room, what's going on behind the scenes, and maybe even recognizing that pharmacy is out there doing a whole lot more things than supporting just the OR. So those are the conversations. So those are the things we're going to look at today. But before we get started, Zahara, why don't you just introduce yourself to us and let us get to know you better?
Yeah, sure. So my name is Zahara, and I have been a pharmacist I got my doctorate in pharmacy when I was 23 years old, a little bit in a hurry.
Yeah.
And so I've been practicing for, I hate to say it now that I go back, but for a long time. And and I was married to an anesthesiologist. So we actually traveled to several regions within California. And so I got really exposed to the different practices and really the surgical world from his eyes and from what was happening behind the curtains. And interestingly, as a pharmacist, historically, when I started, we were just barely trying to push through the clinical world. We were really known as like the pill packers and whatnot. So I was part of that revolution where we really started to engage with our physicians, our providers, and really took ownership of the clinical care of the patients, and were able to provide a lot of assistance. And to see this world has changed so much from me having to like force my opinion into an unsafe medication treatment to now having all residents and physicians call us and say, what do I do? I don't know what to do. It's so, it almost puts shivers in my back. So really excited. But through my ex-husband's experience as an anesthesiologist, I learned a lot of things that what we call behind the black door. So to us in the inpatient setting, the OR has always been the black door.
Interesting.
In the past, and once I became involved as a leader about over 10 years ago within pharmacy space, I really started to have to enter that black room, and we started to really look at the practices and really intervene and support and provide all sorts of services that they weren't aware that we could provide. So the collaboration, the opening of our eyes, so much has changed just in the last 5 years, I would say.
That is okay. First of all, the black door. I always think of the red line. Now you got black door too. Man, that's an interesting thought. But I mean, I guess it is kind of a dark void to anybody who never comes back there. Doesn't see what we do. But to think too, to understand more about what pharmacy is doing in supporting surgical care. What does pharmacy's involvement in the surgical process look like?
It's quite extensive. And I think that just to give you some insight about how my position was created, we had a very sad sentinel event happen at the organization. It was not the first. It had happened nationally on multiple other occasions where during a medication shortage, the product we used to replace that shortage was incorrectly administered in the OR, prepared, compounded in the OR, and it caused a very severe harm to a very typically healthy, short procedure patient. So that kind of created my position, and it's probably the only one within the organization right now, because our services are so large in this area. So that's how this came about, to figure out what is happening there. How can we provide the same kind of support, level of care, level of help to the OR team that we're providing in the inpatient team on a day-to-day basis, and realize how much they needed it and how, I guess, the need was truly there.
It's interesting because I've worked in different places where you have pharmacy that's located right there in the OR, and then you have, places where pharmacy is on a totally different floor than where you're at. So I was just kind of wondering, how do pharmacists work with anesthesia or OR staff to ensure that safe medication use is happening in the OR?
A really interesting point. We actually went to a whole, what's called a satellite pharmacy model over the past decade, where we started putting pharmacists at each unit. They were really specialized within those areas. We're really able to provide hands-on support. And then at some point, as more pressure came about making pharmacy more efficient, and the pharmacists that maybe didn't have a patient that day, or, they started to have to cross coverage multiple units, it just became like, why are we wasting a pharmacist in the OR when the cases are done by 2 p.m.? No, let's remove them. Let's centralize it again. So we went from centralized to satellite and back to centralized. And it's like, so how do we keep the work efficient? The pressure of finances, staffing, this was a problem. So really trying to figure out where can we put these pharmacists that would be optimizing the process. And we'll kind of go over the roles, and I'll break down the answer. I think you talked about how do we support anesthesia. Mm-hmm. Anesthesia is our biggest, you would say they take the biggest size of the pie. They are the one that deal with medications on a continuum basis. They're the ones that have the most shortages. They have the most discrepancies. If that makes sense.
Really? Is that
the most? And you're also going to have the most negatives, I guess, right?
Yeah. You know what? And I try to explain it to my staff. Listen, they have a patient all of a sudden go from flesh color to blue color. At that point, they're not thinking about decrementing what and putting it where. They're just grabbing what they need to and saving that patient. So, we cannot expect them to be able to count correctly, put the product back in the right QB. So what we do in pharmacy, we train our staff to constantly maintain, clean up, audit, edit, and correct those medication pyxis or trays or bins or whatever we're doing to try to mitigate, support them, make sure that they're never out of medication, make sure they don't have the wrong medication, the expired medication. And that takes up probably the most time from our staff within any support area, because it's not predictable. We cannot make it electronic to tell us, oh, this doctor forgot to remove this many meds or put this in the wrong bin. It's very manual, and it's where we have the most mistakes and we need the most vigilance.
It's interesting because I remember seeing like our pharmacy tech constantly coming into the ORs every morning and then going through every single Pyxis that we have in each OR, behind the ORs. I mean, I do see our pharmacy tech quite often throughout the day, and it's multiple times a day.
And what makes OR extra special is that we're very limited on when we can enter, and it's unpredictable. So we have to come in at 4 or 5 a.m., put our running shoes on, and just run and try to catch, and try to not only just do what the system says we need to do, but we know we have to double check and triple check that, because most often they need more than what they say they needed. Counts are off, things are moved around, meds weren't discarded. So actually reinventing just the past 2 years of when should we do this. Now some of our site, we moved our text to evenings. So they have all the time to do all this editing, auditing, and we still will get a call from a doctor saying, I start a case right now, I got nothing,
Yeah, you can't win for losing, maybe. I mean, I don't know, because, you talk about showing up to make sure that the Omnicell or the Pyxis or whatever you're using is stocked. And I think one of my biggest frustrations is when it comes to that is, say I've got to pull out bupivacaine, and I go through all the stuff, and I open the door, and it tells me there should be 14 or 15 bupivacaine bottles there, and I go to grab, and I'm pulling hopefully I'm at least pulling the last one out, but sometimes there's not a single one there. So what is it that is causing that discrepancy most of the time, or is there something that you think is probably the problem?
The bane of existence for all pharmacists. You guys are rushed, so you're opening the.
I'm sure we're the problem.
So what's happening is the system is asking you. The doctor's yelling, "Get me bupivacaine." You're like, I didn't ask how many mLs. I don't know how many vials. I'm gonna have 3 more cases back to back. I gotta get to cataract every 20 minutes. So you grab 3 vials. Right. Did you tell the system that? I did not. So does the pharmacy get alerted to refill it? No. So that's how you end up with the tech comes up, refills whatever the system tells it to refill, and then goes back, and there's no alert about this thing being out. And we set our limits like so high so that if you guys even touch that thing halfway, we'll get it. But, we've had techs have to go back and forth multiple times. They're like, oh my gosh, this only has 1. This told me it has 6. So we're constantly playing catch up. We give more grace to anesthesiologists because it's more life-saving, and so we created trays, but for a typical nursing unit's OR, pre-op, PACU, that becomes very difficult. I cannot run, for anesthesia, we'll actually take extra meds or common meds just with us so that we can fill. And there's all sorts of regulatory compliance that we have to do for that. So it gets very complicated. So, yeah.
And probably incredibly frustrating on your end to show up, think you're stocking one thing, only to find out, oh, really, we don't have 4 of these other medications, but we didn't bring any of them down, and now we've got to fill those too, because, like we just said, people are pulling what they're not actually accounting for, or they're pulling extra and not making sure the numbers match. And
keep in mind, these are technicians. So for them to go pull meds and bring it, the pharmacist has to check them. So now they got to go pull the meds, have a pharmacist check it, and bring it back up. So we've had to figure out in what way can we bypass it? What are some systems we can do to minimize that extra work? Because now the tech has a certain number of hours to fill each Pyxis. Wow, yeah. So that extra trip really trips up their whole schedule for the evening.
And it's not just the OR they're stocking. They've got every floor on the hospital that's got a Pyxis or a dispensing machine of some sort. So I can see that compounding your work.
So let's talk about the safety component of this. Now, when you're removing medications under one patient, but you're administering it to a next patient, the system is not picking up if it's the right concentration. It's not doing that double check for you. We're already not able to really scan medications in the OR for verifying administration. So you're bypassing now 2 steps. And so medications like Exparel, these have to be documented on the patient's chart. You have to have a bracelet that tells you for 96 hours, what other drugs can't be administered. We had nurses just picking up Exparel and just taking it to multiple patients. And then there was no record of it in this patient's chart. So no follow-up, appropriate, drug interaction check. None of that was happening. So we had to pull it from the OR and had to put it in pre-op where they have to document it. And so, and it creates now work for everybody. Now the OR nurse is like, I swear we won't do it this time. Please put it back, But it's, patient safety is a huge factor that we have to, these bells and whistles are in place to support you guys, make sure that the system is helping you.
Now, I imagine that these alerts that you're getting saying, hey, this drawer is short and this, that, and the other, like, you're probably getting many of these throughout the day, even if it's accurate and everything else like that. Like, how often would you say that's happening?
So we have a really good system in place, and this is the system that we're supposed to continue to work with. If we have the right data and we know what the usage has been, we look at what's been removed, we look at how much we refill, and based on like a quarterly assessment, we continue to update our counts to that so that you never run out. The goal would be 2 to 3 days. So we want to not touch that QB every 2 to 3 days. So we will give enough space so that it's not constantly running out. If you're running out during the day, there's a serious problem. Either, it wasn't documented correctly, so that we should only be filling once a day and really most QBs every 2 to 3 days. So anything outside of that, something is broken. Either our counts are off or the documentation is off. So we shouldn't be pinged at all for these types of occurrences.
All right. So one of the things that we've run into at my facility is maybe it's regulations. I might be saying wrong rule or word when it comes to that, but there are only so many medications that we can put on the back table and combine in one container when we're opening them. And so like we have a particular injection that we give that's got 6 different medications in it. Well, we can't actually pour all 6 medications into one container and then they draw it up. We have to divide it up into 2 containers and then pull it up. Then the tech pulls it up right beforehand. Otherwise, I guess they consider that we're compounding the medication in the OR if we pour everything together. And I don't understand all of the rules behind it, but I know that you do. So pharmacy obviously does a lot of the compounding, a lot of the special drugs or special injections or things that we need. You get that communicated to you and you compound it. And then sometimes in the OR, we are mixing stuff up ourselves. I want to talk a couple of different things about that, but the first one really has to do with that regulatory side of it. Like, what is it that we can do and what is it that we can't do when we are in the OR mixing medications?
Great question. And it is a moving target. That's why I've spent the past 2 years heavily focused on the new regulatory compliance and what we call USP 797. And I can tell you all about the why behind it. Once I do that, everybody really truly understands it. The Sentinel event that happened was precisely from a compounding of a product, mixing multiple products, complete 100 times the concentration, familiarity. Obviously, that's not a regular thing that you guys do. And there was a double check and triple check. So anything that you're doing that's not, on a regular basis, potential for error. Now let's talk about what is compounding, what's not compounding. What I tell when I do my OR training, and I also train anesthesiologists and our surgeons now, is that it's really not about the terminology of compounding. It's how much potential risk of error and contamination are you introducing to that product. So the more products you mix together, the more contamination. Every time you puncture a vial and you open a needle and you draw and inject, that's one more point of contact in your critical areas for contamination to enter your product. Every time you mix a second item, you are adding potential for pharmacological interaction because the chemicals react with each other. So we typically in our pharmacy have very strict formulas that we check how long are they stable for, how long can they be in a container, can they be in glass, can they be in a syringe, can they be in a bag. So all that, you're bypassing all those checks and balances. And finally, there's a potential for error. Did I calculate it right? Did I drop the right amount? Did I put it in the right container? So now you have 3 different components that you're working with. So what the USB national guidelines did was say, okay, let's minimize risk. How do we do that? Let's keep it to the bare minimum. Let's do no more than 3 chemical ingredients together, right? Which would mean that now there's the potential interaction is minimal. Usually one is a diluent, one might be, fluid. So we're having less risk of those things interacting with each other. Because otherwise you have to do all these studies on stability of those products, like extensive studies. Then they said also it will minimize how many times we're puncturing. And some of the studies we're looking at is every time you puncture these vials, especially with those blunt needles, you're taking off a piece of that top and it may enter your solution, it may enter the patient. Plus all the movement that's happening in the area, all the particles that are entering, you're potentially putting all those in a bag. And then the longer that sits around, that organism can grow. So that's a lot of what the regulations are about. Limited time, limited counts, and limited access is to try to prevent those potential negative outcomes and really limit it to only urgent emergent cases, because as you know and I know, some of our surgeons want everything made in the morning, make it easier, and they're just thinking ease, but they're not thinking now you're getting measured for your complications, your surgical site infections, all those other components.
So in an ideal situation, then we would have like a space in the OR where it's like just for compounding medications, because we do want to decrease that risk of contamination and everything, right? Like kind of cordoned off away from everything else.
In the ideal world, the pharmacy who has a sterile room with so many regulatory compliance checks and triple checks. We get tested, fingertip tested. I show those pictures in my training, and we still grow bacteria even when we use aldous alcohol. So in an ideal world, you have a sterile pharmacy, sterilely trained team make that for you and bring it to you.
So that actually leads into the rest of the question about compounding and about having what we need in the OR, because one of my roles previously as a team leader, I would look at our schedule and there would be some medications that were ordered. Maybe we needed something out for a cancer patient, or we needed some strange combination of drugs that we did not normally use. And we would have to put those orders in, send them to the pharmacy, make sure the pharmacy knew, and then they would show up the next morning ready for us to use in our cases. But what does the communication, I guess, look like for you so that you all know what the OR needs and y'all can have that stuff ready in time for the cases?
That's a whole other component of what I do, because, every case can differ from the next. There are some medications that we know ahead of time. There are some medications that, based on the patient's vitals or situation that morning, we know the morning of the case. And there are some that are once the patient's in the room we need, right? And so we have actually created multiple communication methods to be able to address each of these. When we have medications that for example, mannitol. For a while, there was a mannitol shortage, and also was crystallizing in our ORs because we keep our ORs so cold that by the time we would realize we needed it for a patient, it was crystallized, and now we had to put in a warmer and all these other things. So we started putting those in pre-orders for our surgeons, saying, if you have a patient that needs mannitol, and this is different than our ICU usage, this is more for cataract surgeries, please put the order in the day before so our pharmacy team can decrystallize any bags and make sure it's ready to go for you the morning or the time that's due. So that's one way of doing it. And it does take a lot, because these surgeons enter their pre-op orders months in advance. And so at that point, it creates that barrier. So the next thing we did was we started seeing orders that were needed to be ordered the morning of and compounded by pharmacy, especially like oncological or hazardous drugs that cannot be made in the OR. So then we started creating these chats, like these group chats for the OR's leads with our pharmacy leads to be able to communicate, hey, I have this coming up, and they'll actually try to give us advance notice a day or two if they can. But if it's not up there, then there's immediate kind of intervention by our pharmacy leaders and saying, we got to get this now and get somebody in the OR, get somebody in our sterile room to make it and deliver it to prevent those delays. And then finally, it might be just a run to the pharmacy and just trying to get what you need, whatever you need to do to get the case going.
Well,
but hopefully this system would minimize that.
So I know that you kind of mentioned like you have these like kind of chats or anything else like that with team leads and whatnot. But how does your team collaborate with, like, say, anesthesia providers, nurses, or surgeons on medication related decisions? Like, say you have a really complicated patient who's got like all these different allergies or whatnot, and how would they be able to, interface with you so that way they can figure out what's the best course of action for that patient?
Yeah, great question, and not one to be able to easily answer. We have, I think, depending on who is asking the question, who has learned about it, who is concerned, the physician and OR team will reach out in different ways. Typically, the first line would be our clinical pharmacists who are approving these orders. They will reach out and have a discussion with them. When it's more complicated, like we talked about the lidocaine and the Exparel, we have surgeon that wants to inject Exparel on one side and then start lidocaine on the other side. So now, is that safe? Is it the 96-hour rule apply or not? That gets very technical. That starts to get very difficult for even my frontline staff, nurse, pharmacists to answer. And there's some regulatory issues with they're answering it maybe incorrectly or out of scope. We do then they do reach out to me, and we try to speak to the surgeon, and depending on how persistent they are about doing it, we support our nurses and OR team in documenting appropriately. They take their steps. They provide the necessary, so we provide the, let's say, literature or recommendation to our surgical team. And usually the educators will call me, or the nurse managers will call me, so that they have what they need. They provide that to the surgeon, and then the surgeon can decide, I've been provided this information, I still decide to proceed or not. And that way, our team is protected, and the physician understands their risk versus benefits as well.
These conversations go by entirely too quickly. And here we are. I'm like, well, we haven't even touched on half the stuff I want to talk about. But one thing that we are all acutely aware of, and all of us having come through the pandemic still kind of just feel, is the medication shortage pain and things not being available, or substitutions that we've not seen before, but bottles looking different, whatever. So I want to talk a little bit about medication shortages. How does the pharmacy handle those shortages and then get that information out to probably not just the OR, but to the floor as well? When you have a shortage, what all are y'all doing?
So that was definitely something that I had to revamp when I got here. With 6 surgical sites and through 6 different pharmacies supporting each of these sites, and shortages just varying based on what day you ordered and how much you ordered and how much you used. Our needs were popping up all over the place at random times. And it seemed like I was always just trying to put out fires. When another site already knew about the shortage, or another site had some extras. And so we finally came together and said, this can't continue. We need to have a better way to streamline this process. So another channel Teams group was created with the 6 sites. And what we did was started really looking at how can we streamline this communication, and how can we not be having to put out fires at 6 different sites at 6 different times. So we have this, bigger scope of, okay, when you have a shortage, they'll send out emails, but there's so many shortages that really everybody starts not to even read them, especially our physicians and providers. So they'll just come and order things that the rest of us knew was on shortage for the longest time. So now I'm much more proactive. As soon as I see something on shortage, or one of my buyers says it's on shortage, we start reaching out to those chiefs. We start looking at our regional team to see if there's any recommendations. If there isn't, usually now we are actually more ahead of them. We'll start to talk to our local physicians, our leadership, and say, okay, what are our options? And then we'll start going down the options and have a plan in action. And we, depending on how severe it is or how much of an urgency it is, for OR, it's almost always urgent. And if you notice, it's almost like there's no alternatives, because no one's willing to take chances, try other things, because I know this works. I'm not going to try to take a chance in a surgery. So we definitely have a lot more, and it's much more acute, and it's much more urgent. And OR time is so, priceless. So it's a lot more running around and trying to get as creative as we can. And then we'll look at all of our supply across the area, we'll allocate it, and then continue to work on alternatives. But it's definitely job security for me, that's for sure.
I know I've heard you speak in the past about how sometimes shortages are based on what's a national shortage due to, manufacturers being, put out of service for a little bit. Or sometimes there's a shortage based on your facilities only allowed to have a certain amount of medication on hand. Can you talk a little bit about that?
Yeah, I would love to. This was definitely a learning lesson for all of us. And I think this really became, so there's a shortage when drugs are on a shortage, the manufacturers can put you on what's called allocation, because they don't want you to hog everything, especially for a while. Those black market people are buying everything up and then upselling you.
Yeah.
But what Stella is talking about is a much more serious issue. When the opioid pandemic happened and lawsuits were filed against the manufacturers, everything stopped. So it kind of got to a point where the manufacturers who were producing the powders, let's say for fentanyl, for morphine, for your narcotics, were limited on how much they can buy. And then the manufacturers who were purchasing the IV, the fluids, the actual end product, were also limited on how much they can purchase. And so they started limiting us on how much we can sell. A few things happen. If they feel like we are ordering beyond our needs, our historical need, they'll kind of go back and they'll stop and say, why are you doing this? That's one of the ways that we get stopped. So if something is on shortage for 6 months and all of a sudden it comes back and we try to buy a bunch, like, nope, you haven't used it for 6 months. We're going to go, we're going to have you ramp up again. But more importantly, issue that we were having was on sites that were wasting a lot of these narcotics and their usage was so high compared to the volume of other prescriptions they were selling or other medications they were selling, the size of the facility. Some of the surgery centers are a lot smaller than hospitals. When we do some heavy sedation in those areas, they start to say, you don't need this for this type of level of care. And so they'll start cutting us off. And so basically towards the end of the year, you'll start to see narcotics go on shortage. And it's not because it's not available or it's a cost thing. Everyone is limited on what they can order. They've already maxed their limit for what they can have for the year. That could be the whole seller.
This? Who decides this limit? You keep talking about they. Who are they?
These are the gods above. So this is, like I said, this went from everybody has to kind of control. Everybody has had to put these bases because the very top, the people that make the powder, was being limited or cited by the government for overselling, overusing, maybe pushing. I don't want to speak about things I don't know.
Sure. So, but it's government regulation in one way.
I mean, it's an effort. It's kind of like an indirect effort to try to control opioid usage.
Yeah.
And I'm sure it's helped in some ways. We're trying to be more cautious about sedation, but it's causing a lot of problems. I think every time you try to fix a problem in healthcare or maybe anything else, you start creating potential other problems. And so the downstream effects of trying to control how much opioids get on the street is now we don't have enough to treat our patients.
Oh, for sure. Well, and that I was actually just sitting in new hospital orientation a couple of months ago, and the pharmacist came to talk to us, about drug diversion and about all the other things that you get talked to in orientation. She actually told us a story about a hospital pharmacy team that was actually getting the opioid medication. Actually, I think they were getting fentanyl, and then they were selling it. And so it wasn't even going to the hospital. It was actually being diverted to the streets and contributing to the problem. So I can see how we want the oversight and the regulation to an extent because we are trying to stop the problem. But then if the problem is inside the building, I don't know what you do. But still, that's a difficult situation.
Yeah, and I can tell you, there's all these levels. Like because I've worked everywhere. I've worked Bakersfield. I mean, all sorts of places. So we've seen nurses on the floor in the bathroom. We had an ED tech that was found, unfortunately, dead, pre-med, dead in his apartment from just coming to the pharmacy, taking things for the ED. And then we've had a pharmacist that I've had to report. I go, this pharmacist is extremely excited to make my dilaudid PCAs every morning. I'm like, this is a lot of enthusiasm for this kind of drug that is so difficult to make. And my director said, how come no one said anything? He's like, when he reported to the Board of Pharmacy, he's like, I could have lost my license because I wasn't correctly monitoring my staff.
Wow.
Because the bags he was making didn't have a lot of dilaudid in it.
No,
I mean, nothing to laugh about, but it was terrible. It was terrible. So it can happen at every level. This is not, this is not any individual person.
Oh my goodness. Okay. Well, it's mind boggling to think about, the access to the medications and then also the staff in general and all of the things that we've even heard about in the news and drug diversion and things that happen. And that is going to have to be, unfortunately, a conversation for another episode because we have hit our time limit. Before we go, I would like to just ask one more question. And it's really more just about helping the OR understand the pharmacy's role. If there's anything that you could tell the teams in the operating room about the pharmacy, about your role, or about the work that you were doing in the hospital, what is it that you would tell them so they could understand pharmacy better?
Yeah, that's a great question. And I've worked years now in trying to both understand the OR's perspective and try to share the pharmacy perspective. And I think it's a learning, continuum learning. I think understanding that everyone is there wanting to do the right thing and wanting to deliver the best care and service that they can. And I think that, usually if there's something missing, late, delayed, or inaccurate, there's typically a system issue that we have to look at. So rather than getting upset at the individual or at the person, I think bringing the right people to the table, encouraging, and going through your leadership to really have those conversations more often than not, we can find a solution that will help. And I think if everyone understands the why and contributes to that solution more than ever, I think we can definitely remove that black door between the two spaces we share.
And that is an excellent goal to have. Well, Zahara, thank you so much for joining us. I really appreciate you taking the time to teach us about pharmacy. This has been very informative.
Thank you so much. I really appreciate the opportunity and happy to talk some more.
That was Zahara, a pharmacist from San Diego, California, with a lot of inpatient experience being a pharmacist and dealing with the headache, maybe, that comes from interacting with the OR from time to time, but also supporting the OR and the experience and the knowledge that she has to make sure that we're not making medication mistakes, that we are providing the safe medications and all of the things that we need for our patients. And the black door comment, that was interesting. I've never heard black door. I've heard red line all the time, but black door was new. But there was a lot of good stuff to take away and to really understand just what all the pharmacy is doing, and really to really realize that they are taking care of just more than just the OR, and they exist for more than just our department. I think it's helpful to really get just a good view of everything that they do.
Yeah, for me, I was really impressed with all that behind the scenes work that's happening and how much coordination it takes. Because you always think like, oh, it's just getting me the medication that I need. Right?
Yeah, fill up the Pyxis, for crying out loud.
Yeah, just fill up the Pyxis, or just get us the meds that we need. Just order the meds we need, or whatever it is. And you never think about like, oh, okay, well, in order for the pharmacy tech to be able to come and fill the Pyxis, the pharmacist has to check every single thing that the tech is bringing down. And so there are a lot of behind the scenes things going on. And, maybe it's just going to make me a little bit more patient when I'm calling and asking for these things. So.
For sure. And, that's probably the goal for all of us, to really help us, what do they say? Walk a mile in somebody else's shoes, right? To really understand what all of the constraints that they are under, so that it helps us understand maybe we're waiting, for a reason. But also, Stella, you are an excellent co-host today. Thanks for joining us and for helping us have this conversation. Your insights, as always, are very helpful and just added a great perspective to our conversation. So thank you for being here.
Thank you. Thank you. I've always been a super fan. So
yes, you are a very first super fan too.
I was like, yes, fangirl.
Yes,
so
absolutely.
Very happy I could be on.
Well, I'm glad you were here. It was helpful to have another voice. And for those of you wondering, Chris has not gone anywhere. Chris has just been incredibly busy this season that we have been recording. And so she's dropped in for a couple of episodes. I've done several of them myself, and Stella was gracious enough to join me for this one. So that is going to do it for this week's interview. On behalf of Chris, myself, Stella, and our whole team, thanks for listening to this week's episode of First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.